It's my pleasure to welcome all of you to the sixth day of World Antimicrobial Awareness Week webinar series brought to you by Manipal Center for Infectious Diseases and Department of Infectious Diseases, Kasturba Medical College, Manipal. Myself, Dr. Kavita Sarao, I am the professor and unit head at the Department of Infectious Diseases at Kasturba Medical College, Manipal. For us to have a very successful career in infectious diseases and microbiology, we need to have a good foundation and strong basics related to bugs, the susceptible interpretation of the susceptibility pattern and culture reports. And so today, to give a lecture on this very important topic, we have our speaker, Dr. Akshatha Ravindra. Until recently, she was the assistant professor of Department of Infectious Disease at Kasturba Medical College, Manipal. She had her early training MBBS from Mysore Medical College, Mysore, and went on to do a clinical microbiology training from JIPMER and further the DM in infectious disease from AIMS Jodhpur. She holds many leadership roles as the ISID council member, and she has multiple roles in SMIT, Parity Commission, Professional Affairs, and also she is a young SPID country representative and country ambassador for Royal Society of Tropical Medicine and Hygiene. She is a member of the SMIT review evidence review group and also sits PG subcommittee. She was a core committee member of Manipal Center for Infectious Disease at Kasturba Medical College, Manipal. More importantly, she has her own YouTube channel. She's the founder and host of Learn with Dr. Akshatha, which is very popular. She has many awards and achievements to her credit. She is a SME TAE Outstanding Trainee, ID Week Trainee. She has an award for that. Young Researcher Award, author of 10 book chapters, and also she has multiple publications already. So over to you, Akshata, for this lecture. We are waiting for this.
Thank you, ma'am. Thank you for the kind introduction. So without any further delay, I'll be starting. I'll be sharing my screen. I hope my screen is visible. I'm audible.
Yes.
Okay. So today the topic which I've been given is making sense of culture reports, culture and AST reports. So before I start any topic, this is the fundamental question you need to address: why, what, and how. So why is this topic relevant with regards to the WAAW which we are discussing? As we all know, antimicrobial resistance is accelerating globally, and misinterpretation of the culture and AST is one of the contributors which leads to unnecessary broad spectrum usage, failure to de-escalate, and increased cost and toxicity. So accurate interpretation of the culture reports and AST is one of the cornerstone of the antimicrobial stewardship. According to the AMS definition, we have the right antibiotic for the right dose, for the right duration, and the right patient. To achieve this, you need to interpret your cultures well. So these are the content of my talk. I'll be discussing about the culture reports and the AST. In the culture reports, the steps of reading and various cases. In AST, important concepts, the types of AST, steps of reading AST reports, understanding gram-negative and gram-positive resistance based on the cultures, and various cases. So what are the things you need to check in a culture report? The culture report has these fundamental components. There'll be gram stain, which will give the type of organism, gram negative, gram positive, yeast, etc. Number of colonies, that is the CFUs, which you see, colony forming units. Then the growth pattern, whether there is a single type of growth or mixed flora or multiple growths. Then the site, there will be mention of sterile site or non-sterile site based on the specimen you said, like blood, CSF, pleural fluid. All these are considered to be sterile sites, whereas non-sterile are your pus cultures, your tissue cultures, etc. And in blood culture reports, you have something called time to positivity. So how to read a culture report? The first question you need to ask is the quality. Is the sample good enough? So the quality depends upon how correctly you have collected the sample. When was the sample collected? Was it before the antibiotics? Have you sent the adequate volume for the cultures? As well as whether it has been transported quickly and properly. So there are various clues in a culture report which will give You answer regarding the quality of the specimen, like there is a note about the epithelial cells, which will indicate higher the epithelial cells, more chances of contamination, especially in your urine and sputum samples. There can be reports of written as mixed flora, which could indicate contamination. Low colony count units could be an indication. Single positive blood culturing when you have sent multiple sets could be due to the skin flora contamination. So remember, bad sample is equal to bad culture and misleading AST. So the second question you should ask is the growth. Is the growth significant? So there will be a lot of colony forming units like 10 power 4, 10 power 3. You need to understand what is significant for what type of specimen, which I'll be discussing a little more in detail in further slides. And remember, in blood culture, same organism in more than two bottles and higher, lower, faster flagging, that is lower time to positivity indicates it's a pathogen. And in general, more than three organisms is contamination. And third question is the organism a true pathogen? Is it clinically relevant? Is it a colonizer or a contaminant? So you need to understand what the various definitions, that is the commensal, what is a commensal, what is a colonizer, what is a pathogen, what is a contaminant. So commensal is the organism which has established in your body early in life. Majority of the population will have this in their body, and there will be no apparent damage to the host after the primary entry. Next, we have something called the colonizer. These are the organisms which have gained entry in later part of the life, and there are a set of individuals who may be colonized. This may be transient or persistent, but it is not associated with the disease process. Then we have contaminant. This is some organism which have been introduced from an extraneous source, that is external sources, like during the sample collection. The pathogen is the organism which elicits the immune response and causes the injury. So what are the various pathogen? Common contaminants include your cons, that is coagulase, negative staphylococcus, your corynebacterium, bacillus species, or gram GPBs, what is seen, micrococcus, etc. Colonizers, you have lot of colonizers, and most of the time the colonizers are treated instead of the pathogen, like candida in urine. And in any patient who has been intubated, the trachea, the ET tube can get colonized with various organisms which is common in your setting, like it can be crab, it can be pseudomonas, it can be stenotrophomonas. Then skin flora in the wound, so that's why it is not, it's said that you shouldn't be sending wound swabs. So, when should you consider a colonizer or a contaminant to be a true pathogen? When there is repeated isolation, when there is compatible clinical syndrome, and when you know the quality of sample which you have sent is high quality. The fourth question is the comments. It is all the microbiology reports will have some comments. So which will help us to understand whether it's a poor quality sample. There will be notes on the intrinsic resistance. There can be some of many of the reports will have suggested preferred drugs as well. Then there will be phenotypic patterns like whether the organism is ESBL, carbapenem producer, MRSA, VRE, that is vancomycin resistant enterococcus, and infection control alerts. So these comments are, you have to read it and should not be skipped. The fifth question is, does the culture actually fit the patient? So always, it's not the cultures you treat, it is the patient you're going to treat. So always correlate your cultures with the symptoms, the presence of fever, WBC, the biomarkers, imaging, various risk factors the patient may have. So a culture that result does not, which does not fit clinically should not determine the therapy. So this is the checklist which I was talking about. Whenever you look at the before starting the antibiotics, so was the sample adequate? Is the growth significant? Is the organism a real pathogen? Are there any warning comments present? And does the result match to the clinical picture? And if you are not able to understand, definitely do not hesitate to calling your lab. Your maybe if you are talking about culture reports, the microbiology lab or other reports, you should be talking to your pathologist. So when in doubt, call and clarify regarding anything. So we'll start with the case. A 55-year-old man with COPD and diabetes, presents with increasing cough for 3 days. He has some low-grade fever, increased sputum production, but no hypoxia. There is some mild wheezing which is present. And the sputum sample is sent, and this is your report. Gram stain showing more than 25 squamous epithelial cells, and there are few WBCs, and there is mixed flora which is seen, which includes the GPC, GNB, and some gram variable organism. So the culture report is saying heavy growth of mixed organism. So the interpretation which has been given is suggestive of oropharyngeal contamination. Should you start the treatment based on this? So this is where your culture report will be useful, especially in cases of your sputum sample and your respiratory sample. There are certain normal floras and there are certain threshold for the significant counts. So uh, and what is important in the report is your present, rather than the presence of WBC, you need to look at the presence or absence of these epithelial cells. If there are a lot of epithelial cells, they have a scoring system as well, Bartlett scoring system, which they'll be using to signify whether it is a good quality specimen. But in general, you remember if there are more than 15 epithelial cells, your significance of the sample or the quality of the sample is poor. It is generally more saliva than the sputum. So the significant count for sputum is more than 10 power 5 CFU per ml. ET aspirate more than 10 power 5, ball or mini ball more than 10 power 4, and protected specimen brush that is more than equal to 10 power 3. And some of you may be getting the reports of light growth, moderate growth, heavy growth. So this is how they are going to quantify based semi-quantitatively. So this is how a culture plate will look, where they will do the initial inoculum followed by first streaking, primary streaking, secondary streaking. So based on the growth, like if it is seen only in the well, it is scanty growth. If it is seen in the first quadrant, it is determined as light growth, and so on and so forth. And how are you going to get this? Again, there are standardized loops which will be used, which you will be getting this. If you see the growth based on the standardized loop, there will be report of these colony counts. And there are a lot of organisms which are the normal microbiota or microflora of your respiratory system. Usually, what including your streptococcus pneumoniae, like around 30% of people will have streptococcus pneumoniae. So in that situation, how are you going to interpret is the predominance. So whenever I have also mentioned, the colony count also plays a role whether it is a pathogen. So if it is a predominant streptococci pneumonia, then you can consider it as a pathogen. But if it is a part of with other flora, then you will be considering it as a common respiratory flora. So these are the various organisms which includes your gram positive, gram negatives, and your anaerobic organisms. But if it is a proper sputum sample, you don't expect this. So usually when the quality of the specimen is not good, when you are seeing the saliva, that is when you will see all these flora. So let's go to the next case. A 30-year-old woman, otherwise healthy, presents with burning icturation, mild suprapubic pain. There is no fever, no flank pain, and symptoms was for 1 day. She gives the urine sample, which was said there was no proper instructions given with regards to how the urine sample should be collected. And this is the report you're going to see. Urine routine shows epithelial cells of 20 to 25, WBC of 5 to 10, mixed bacteria seen, glucose estrase is trace, nitrate is negative. Urine culture report shows mixed growth of three organisms, E. coli, Enterococcus fecalis, and cons. And the colony count is 10 to the power of 3 to 4 for CFU per ml for each. And there is AST also which is provided. So are you going to treat this patient based on this? What does the patient have? The symptoms are suggestive of cystitis. And so this sample is a highly contaminated sample. That is why where your instruction, how you give the instruction to the patient becomes important. Uh, So you need to instruct, especially in cases of females. It is there is a lot of flora in the vagina, in the perineal region. So you need to instruct well how the sample or the urine sample should be. That is a midstream clean urine that is to be collected. So you and if there are in urine culture, if there are more than three, it should be reported as contaminated and repeat sample, and no AST should be performed unless there is one predominant organism and others are insignificant counts. So, what are the significant counts in case of urine sample? In case of non-invasive urine, that is your midstream clean catch urine, more than 10 power 4 also can be significant. In invasive urine, uh, that is your PCN sample, suprapubic aspirate, more than 10 power 2 to 10 power 3 is considered as significant. If there are two isolates, then if one of the isolate is more than 10 power 4, it is considered as significant. If there are more than three isolates, it's most likely contamination. So next case, a 48-year-old diabetic man presents with acute onset of left knee pain, swelling, warmth, and fever for 1 day. The knee is extremely tender and there is severe pain on passive movements. Arthrocentesis is done and the synovial fluid shows it is turbid. WBC count of 85,000. Glucose is low, protein is high. Gram stain shows gram positive cocci in clusters. So, how does this make a difference in your therapy? Gram stain is the first clue you get it. So, this is especially useful in certain settings like your CSF, where if you see encapsulated yeast cells, you're going to think of cryptococcosis. If you're seeing GPC gram positive cocci with capsule, you'll be thinking of in terms of streptococcus pneumonia if you are seeing gram negative cocci. So that's why you need to understand few important terms, like if you are seeing GPC clusters, more likely to be staph. GPC in chains, short chains is your enterococcus, long chains is your streptococcus. You can see gram negative rods, that is GNR, which can be due to any multiple organism like enterobacterial, pseudomonas, etc. And remember, yeast, if you see, that is more likely in is likely to be candida. But again, even if there is budding yeast cells with pseudohyphacine, it should not be considered as a significant or the pathogen in case of your respiratory samples and your urine samples. And even the Gram-stain, you can also assess the inflammation, whether there is neutrophils present or this WBC is present or not. So Gram-stain will guide the early therapy and also can predict the contamination. So Gram-stain is equally important to the equally and more important than the culture. Next, we move to the next case. A 55-year-old ICU patient with a central line, that is on day 6, he developed fever, hypotension, and blood cultures have been sent from central line and peripheral line, which is growing. Central line has flagged at 10 hours, that is growing Enterococcus faecium, and peripheral sample again is growing Enterococcus faecium at 22 hours. So, how are you going to interpret this? Is this CRBSI or GLAPSI? So that is where your DTP, that is differential time to positivity, is important. The central line flagging before than the criteria central line should flag before the peripheral line, and the differential that DTP should be more than equal to 2 hours. So this indicates it's a CRBSI and both of them are growing same organism, so it is a true bacteremia. So how to interpret this? Look at the central line first, then the peripheral line. If both have grown same organism more than equal to 2 hours, then it is CRBSI. Less than 2 hours, it is not CRBSI, but definitely that is a bacteremia. You need to find out the source of this bacteremia. That is, the central line is not likely to be the cause of the bacteremia. If only central line is positive, it is most likely to be central line colonization or contamination, depending upon the type of organism you're seeing. If you're seeing only peripheral is positive, the infections can be from other source. Again, you should always rule out whether the sample which was sent was adequate and sent properly or not. If it is flagging at the same time, it could be indeterminate. You need to decide. So what are the common blood culture contaminants which you see? Most common is the cons. that is your Staphylococcus epidermidis, hominis, hemolyticus, capitis, etc. So again, remember these all these contaminants. If it is like if you are sent like 3 to 4 bottles and only one bottle is flagging cons, then it could indicate contaminants. But if you are seeing three of the bottles which is growing cons, then you should also consider it could be a pathogen. Again, remember many times though there will be multiple bottles sent, it should be from different pricks, not like I did a prick, I mean I drew sample of around 10 to 15 ml and I distributed in 2 to 3 bottles and sent. That is not how you are going to interpret. Then other common contaminants includes your Corynebacterium, that is you call your diphtheroids like Corynebacterium striatum, Gecum. So these are some of these organisms are also causative agents of infective endocarditis, but that is where you are going to differentiate. If it is a single bottle, it could be contaminant, but if you are seeing multiple isolates, then you are going to consider in terms of it could be a significant pathogen. Other common contaminants includes your Bacillus species, Cutibacterium, Micrococcus species, and a viridans group Streptococci also, because it's one of the oral flora. It is contaminant unless repeat cultures or endocarditis is suspected. So again, note, if the same organism grows in more than two, contamination is less likely, and there are certain organisms which are always pathogens, unlikely to be contaminants, which includes Staph aureus, E. coli, Klebsiella, Pseudomonas, Candida, Streptococcus pneumoniae, Enterococcus. So next I have set of questions whether like based on what you have learned till now, whether you're going to treat the patient or not treat the patient. So this is a patient. I would request all of you to use chat. I wanted to use the polling option, but due to the shortage of time, I will not be using. So treat or not treat. A 60-year-old male with locally advanced CA tongue post-chemotherapy is currently under PMD care. He's afebrile, reports mild cough, and this is the sputum report. You see the sputum report here, 15 to 20 epithelial cells, many pus cells, and organism is Pseudomonas and E. coli. Treat or not treat? Lot of epithelial cells should not be treated. Correct. And the patient is quite stable. So treat or not treat, a 62-year-old diabetic male with a non-healing post-surgical wound. He develops low-grade fever and local erythema. Pus culture is showing this report. That is pus cells, the gram stain shows pus cells numerous, no bacteria. Should I treat? Is a diabetic, basically a diabetic foot ulcer. Treat. Okay, so again you should see whether that was a wound swab or not. If it was not a wound swab, definitely consider to treat this patient. And remember, diabetic foot, many people, most of the people are colonized with the hospital organism, including E. coli, which is a carbapenem resistant. So ideally, the if you have you should have sent the surgical debridement cultures, not the wound swab. Treat or not treat. A patient is posted for knee replacement surgery. Here, urine culture is showing pus cells few, gram-negative bacilli seen, and Klebsiella pneumoniae. Should I treat this or no? I have not mentioned any symptoms. So there is no symptoms, then do not treat. No, asymptomatic bacteremia should not be treated, irrespective. Only to a few conditions where asymptomatic bacteria should be treated is pregnancy, and you've posted for urological procedures and renal transplant within 1 month. Treat or not treat, ICU patient with Foley catheters, Foley's catheter in situ is afebrile. There is some leukocytosis, like you can think around 11,000 to 12,000. Culture report shows urine WBC present, no organism. Urine culture goes Candida albicans, 10 par 5. Should I treat or not treat? So definitely this is one of the commonest scenario. Any patient with so fever in ICU, it's not an indication to send pan cultures like urine culture, blood culture, respiratory culture. They'll be colonized, and urine WBC does not indicate infection. Even the reaction to the Foley catheter could elicit the WBC response, so should not be treated. So remove the catheter and send fresh, replace the catheter and send fresh sample. Treat or not treat, a 45-year-old male, stable vitals, admitted for elective surgery. He has no fever. Blood culture, one bottle shows cons, other bottle no growth. First of all, there is no indication to send blood cultures for all the patients who are posted for surgery. Should I treat only one bottle? Definitely do not treat. Next patient, a patient with fever and central line in situ. Culture report shows line tip culture more than 15 CFU of cons, and peripheral blood culture is negative. So this is one of the things which is commonly practiced. That is line tip cultures. You remove the line and send it for culture. So this is a practice which should not be done. So this should not be treated because this is a colonization of the line. So you just remove they send the tip culture, that means it has been removed. There is no indication of systematic antibiotics. It will be indicated only if the blood cultures what you sent is positive. So do not treat line colonization as bacteremia. A post-operative patient with signs of peritonitis, culture shows mixed enterobacterials plus anaerobes. Should I treat or do not treat? So, yes, this is one place where even there is mixed cultures, you should be treated. Patient has peritonitis and it is expected. The culture report of the drain fluid can be having multiple organisms, especially anaerobe mixture of anaerobes and your E. coli, enterococcus, etc. So you should be treating this. It's a true infection due to intra-abdominal source. Requires source control broad spectrum. Then you can de-escalate. So some of the cultures where polymicrobial way are meaningful, that is especially in case of these abdominal infection. In sputum, it is not. Sputum and your urine, it is not. Treat or not treat, a patient admitted for elective surgery, no infection. Culture report, nasal swab was sent and which shows MRSA colonization. Should I treat it or do not treat it? Okay, there's mixed response. So it's not again, if you want to treat it also, it's not treatment, it is decolonization. It's not starting systemic antibiotics, and it's not recommended that all the patients will. Again, it depends upon hospital to hospital policy. This is you. The nasal swab is used for screening purposes only. No systematic antibiotics is required, and decolonization is required only when it is indicated. So colonization is not equal to infection. Treat or not treat. Initial gram stain from a blood culture bottle shows GNB. Final culture, that is after 5 days, is no growth. I am sure it is one of the commonest scenario. Should you treat it or no? So again here, why does this happen? Because it could be a fastidious organism because of prior antibiotics, and there can be some lab processing issues as well. So when you see a blood culture growing, showing GNB, patient should be started on empiric therapy, but then you have to reevaluate when the final cultures are negative. You can send repeat culture if it is happening, and if and you can continue the treatment if the patient that is you feel it is clinically relevant and should be treated. So gram stain positive plus culture negative, you have to be correlate clinically. Next, a patient on antibiotics comes with complaints of loose stools for 1 day. Routine stool culture shows no growth. Stool PCR has been sent, which shows C. diff toxin PCR positive. Uh, Antigens is negative. Norovirus PCR is negative. Should I treat this as C. diff or no? Okay. Yes, correct. Should not be treated because toxin PCR is not the patient. It's not a C. diff infection. PCR positive start metro is not required. PCR toxin negative indicates colonization and not the disease. It should be treated only if there is compatible syndrome, that is more than 3 watery stools plus compatible clinical picture. You should always interpret stool PCR carefully, and it's very common to overdiagnose C. diff. Let's move on to the interpretation of AST. These are the various AST methods which is there available: disk diffusion, MIC, E-test, automated tests like your Vitek. So what is disk diffusion? It's a qualitative method. You use fixed concentration of the antibiotics and you measure the zone of inhibition. In MIC, it can be by agar dilution, broad dilution. It's one of the quantitative methods, and this is a gold standard for AST. So E-test, it's a combination of distribution. Basically, you have a strip which is incorporated with various dilutions of the antibiotic, that is graded dilution, and it gives the MIC. Then we have the automated system, which is in general based on broth microdilution. So this is how the process of AST. Once you have the culture organism, that will be you are going to make a inoculum, and then you're going to do a lawn culture, and you're going to put up the antibiotic disc, and this is how you're going to see the disc diffusion, that is line zone of inhibition. And ideally you should measure it by a vernier caliper, which will give the diameter, and that diameter you're going to compare with the breakpoints which is available and give the report as susceptible, intermediate or resistant. And this is the microbroth dilution, micro titer plate, and the E strip. Here we, as you can see, there is a gradient of the antibiotic, and then you're going to see the zone of inhibition, and where it touches the elliptical inhibition zone touches is the MIC. And microbroth dilution, it is the you are going to look at for the clearance. So opaque zone indicates the organism is present, and again here there will be gradient of the antibiotics, and where the lowest dilution which inhibits the growth of bacteria is considered the MIC. And there are certain important concepts in AST. What is MIC? Is the lowest concentration of the antibiotic that inhibits the visible growth of bacteria. MIC does not directly correlate with the patient outcome, and MIC is not equal to the break point. So the MIC value is dependent on the drug and the organism. It's not like there is a MIC for amikacin. No, there is MIC for amikacin for E. coli, and they can be and never you can compare the MIC of two different drugs. And lower MIC is more potent drug, but it must be with relevant to the break points, which I'll be discussing later, and it is reported as a number like 0.5 microgram per ml. MIC is alone meaningless without the breakpoint. That is, the susceptible, indeterminate, and resistant depends upon the breakpoint. And you cannot directly correlate the diffusion zone to the MIC value. That is, larger zone the equal to lower MIC. It is not. Then there is breakpoints. So breakpoints are given by different societies, which determines like a value which differentiates the organism or the into susceptible, indeterminate, and resistant. And this is based on the PKPD, clinical outcomes, population MIC distribution, etc. And it is different for each organism drug pair. Like for E. coli, meropenem, this is the breakpoint. E. coli, amikacin, this is the breakpoint, and it is not same for all, and it changes or updates every year. You need to be you need to ensure that your lab is updated with the CLSI. And in general, there are two bodies, CLSI as well as UCAS. In India, most often it is the CLSI which is used. And breakpoints are different for MIC and distribution, and they are not interchangeable, and the breakpoints will differ based on the site of infection. Common one is the meningitis and non-meningitis. The dose of the antibiotic also depends, because and route of administration I will be discussing later. And in general, remember, the breakpoints are based on the MIC or the levels of the drug which is achievable in the blood. So which method is better? Is disc diffusion better? Is MIC always better? There are certain drugs which disc diffusion is not reliable, like vancomycin, colistin, daptomycin. Their MIC is mandatory. So these are the list of organisms and the drugs like vanco, dapto, colistin. Your disc diffusion should not be done. And there are various other organisms like fastidious organism where there are no defined disc diffusion breakpoints, so you should not be doing disc diffusion. And many times the CLSI, previously there was disc diffusion breakpoints, and now the disc has been removed, and they have reported that it should be reported by MIC, like in case of your Burkholderia species, Stenotrophomonas. There have been a lot of drugs which the disc diffusion breakpoints has been removed. So is Vitek always reliable? Definitely no. So there, especially for colistin, Vitek is not reliable. So what am I supposed to do? You cannot do disc diffusion. I cannot do Vitek. You have to do broth microdilution, or the drug elution, which is the gold standard. Otherwise, you should take the reports with a pinch of salt. Then for Staph aureus, vancomycin, teicoplanin, MIC by the VITEC is not ideally is inaccurate. So it is recommended to do E-test or broth micro dilution. So what are the steps in AST interpretation? First, confirm the organism ID. Then what method, whether it was disc, diffusion or the MIC. Look what these are the contents, like whether then you look at the susceptible, indeterminate, resistant breakpoints, and then the various resistance mechanism can be specified and the comments. The step one is confirmation of the organism. So, for example, Staphylococcus aureus, cefoxitin is used as a MRSA screen. Then verify the AST methodology. This diffusion is by Kirby-Boyes methods. MIC, that is E-test or micro-broad dilution, or the automated, and ensure it follows the CLSA and UCAS. These are the two bodies which gives the breakpoints. CLSA is updated every year, and use or the select the correct breakpoint standard based on one of it. So you cannot test by one method and change it, like interpret using the UCAS, because the disk strength everything will vary. So you should be familiar with what your lab uses. There are certain drugs where CLSA breakpoint is not there, so UCAS can be used, and this breakpoint will vary based on organism, infection site, antibiotic dose and PKPD. And remember, it is not sensitive. No organism has feelings. So it is susceptible. S means more likely to work, indeterminate or increased exposure. There are two different terminologies which is there, which I'll be discussing. And resistant, the drug will not work. Again, these are the AST interpretive criteria or categories by the CLSI, which gives susceptible, indeterminate. There is a high dash which gives as a high concentration in urine, and we have something called SDD, susceptible dose dependent. It is certain drugs which you can use at higher doses for achieving the response. Then we have the resistant breakpoint. In UCAS, we have S, I, R and ATO, area of technical uncertainty. So in CLSI, these are the various SDD categories. Why is this important? Because usually what we do is the sensitive drugs only we are going to choose and only use that drugs, and not intermediate as well as resistant, definitely. So in case if it is mentioned as SDD, you can still use the drug, but you should ensure that you use it that at the dose. And for each MIC or each breakpoint, there is a specific dosing of the drug which is mentioned in the CLSI only. So SDD organism, especially one of the commonest one is cefepime for enterobacterials. So MIC for susceptible is 2, and for that is the breakpoint is 4 to 8 for SDD. So based on if it is a MIC is 4, MIC is 8, there is a different dosing and the dosing interval which is mentioned. Then look for the red flag resistance pattern. So whether you're looking at, if you're looking at Staph aureus, look at the cefoxitin. If it is resistant, it is MRSA. Then for enterobacterials, look at ceftriaxone. If it is resistant, more likely to be ESBL. And in case of enterobacter species, cefoxitin, again look at cefoxitin for AMC producer, carbapenem for carbapenem resistant. And in cases of your gram positive, especially your staph, look at the clinda. If there is clinda susceptible, erythromycin resistant, it could be an MLSP, inducible MLSP phenotype, where the erythromycin can induce resistance in clinda, so avoid clinda. Then you should know your intrinsic resistance. This is one of the important steps. There are some drugs which must never be used even if the AST says. Ideally should not be reported. Even if it has been reported, if it says susceptible also, you are not going to use it. So what are these intrinsic resistance? Few important ones are Enterococcus for cephalosporins, cotrim, clindamycin, Pseudomonas cotrim, tigecycline. Your Proteus and Pseudomonas is intrinsically resistant to your tigecycline. Then Enterococcus cephalosporin ceftriaxone is intrinsic resistant, but only place where you are going to use it in combination is like previously discussed in infective endocarditis. You are going to use it as a combination of two BLBLI like ceftriaxone plus ampicillin or ceftriaxone plus genta. Then for Stenotrophomonas intrinsically resistant to carbapenem, Burkholderia intrinsic resistant to your colistin, and anaerobes are intrinsically resistant to your aminoglycoside. Next, step 7, you should correlate with the site of infection. Some drugs do not penetrate certain sites. So like your BLBLIs, your peptides and all do not penetrate into CSF. So you should not be using peptides in treating CNS infection. In urine, nitrofurantoin oral fosmazine should be restricted for cystitis. And do not use moxifloxacin, tigecycline because they do not have urinary excretion. So choose antibiotics that reach the infective site. And step 8, which is the most important step, choose the best drug clinically. It is based on the severity of infection, organism mechanism, MIC value, organ dysfunction, if it is present or not, drug penetration, local antibiogram. So the AST will tell what can work. It is you who should choose what should work. So these are the various steps in the determination of the AST. That is identify the organism, AST method, check the breakpoint, whether it is CLSI, read whether it's susceptible intermediate, look for the resistant mechanism, know the intrinsic resistance, match the drug to the site of infection, and then choose the best antibiotic. So can I identify the same in culture report? Can I choose or identify the resistance? So coming to the gram negative part, more in case of your Enterobacteriales, which is one of the commonest organism, you can interpret. So there are three main important antibiotics you need to look at: ceftriaxone, peptides, meropenem. If all of them are sensitive, there is no beta-lactamase. If there is ampicillin is resistant, narrow spectrum beta-lactamase. The most common scenario is the ESBL, where it will be ceftriaxone resistant or MIC will be more than 2, and but sensitive to your peptides. Then you have your AMC. It is the ideal surrogate marker for AMC is cefoxitin. If your lab is testing that, if it is resistant, it indicates AMC producer. Otherwise, based on ceftriaxone as well as BLBLI, which are resistant, you can assume the AMC. Again, remember all these are, you're going to assume it. The confirmation is by a molecular test only. CR, carbapenem, which is one of the simplest one, resistant to carbapenem. Sometimes you can see some susceptibility to BLBLI, should not be relied on. If it is carbapenem or like meropenem resistant, should be considered as CRE. And if you see colistin, there is no susceptible breakpoint. There is only intermediate breakpoint because the PKPD parameters suggest that colistin is never going to achieve enough levels in the drug to sufficient to kill the organism. So how do you, and next important thing you need to differentiate is whether it's an MBL or non-MBL, metallo-beta-lactamase. How are you going to decide? Why are you going to decide? Because your combination therapy, ceftazidime, avibactam with aztreonam, whether you can give or no, that is how you are going to decide. If it is MBL, you are going to give combination. So how are you going to determine? If it is MBL, ceftazidime, avibactam will be resistant with your aztreonam may be susceptible or intermediate. In non-MBL, it will be ideally susceptible. Then coming to Pseudomonas, again there are the Pseudomonas, there can be resistance due to the hyperexpression of AMC, porin mediated efflux pump, carbapenemase or MBL and non-MBL. So efflux pump mediated resistance will be resistant to your ceftazidime, cefepime and peptides, whereas susceptible to your carbapenem, whereas porin mediated will be resistant to your carbapenem but susceptible to the lower drugs like ceftazidime, cefepime, peptides. In this situation, the IDSA also recommends you can use these drugs but higher dose and longer infusion. So I do have some cases. Can I take that up, ma'am, or I will stop due to the time?
You can take for 5 minutes.
Okay, ma'am. Thank you. So one of the few important in gram-positive scenarios, MRSA, there is something called MRSA creep, and this is the actual phenomena. So this was a patient, a blood culture showing vancomycin MIC on day 1.5. On Then on day 3, the van MIC was 1. So what is MIC creep? So there will be slowly increasing the MIC on treatment. So when the MIC is between 1.5 to 2, ideally, even though it is in the susceptible range, it is better to use an alternative. And vanco susceptibility, this diffusion is not recommended. MIC is the one which is ideal. And you may remember, VSSA can turn, that is susceptible, can turn into visa during the course of therapy. And if you're seeing resistant to vanco, ideally it should be repeated and sent to a reference lab. And if you're seeing in urine culture Staph aureus, it's not UTI, you should always consider bacteremia. And the term cons has been replaced by the SOSA, that is Staph aureus other than Staph aureus. So what does MSSA imply? You are looking at cefoxitin or oxacillin. If it is susceptible, it's called as MSSA. You may or may not see other beta lactams which is reported as susceptible. But if you are saying cefoxitin susceptible, it implies susceptibility to the beta lactams and the BLI. But the drug of choice remains your cefazolin, flucloxacillin only. Then next important thing is site specific breakpoint which is available for your pneumococcal meningitis. It is very important because there is different breakpoints which should be used for meningitis, that is for penicillin is less than equal to 0.06, for ceftriaxone it is less than equal to 0.5. So because based on this your therapy is going to differ. If it is penicillin and ceftriaxone resistant and the ceftriaxone MIC is more than 0.5, you are going to use the combination of vanco plus ceftriaxone, which if you remember it is one of the empiric choices for the suspected bacterial meningitis. So how are you going to report? So if you are seeing blood report with blood culture growing streptococcus pneumoniae, both have to be reported. Like if it is meningitis, consider this as a breakpoint and this as a susceptibilities. And if it is not, then non-meningitis, like the blood culture can go streptococcus pneumoniae because of the pulmonary infection as well, that is respiratory infection. So you both have to be reported and with the adequate comments. Then in case of sputum, you are going to use the non-meningitis breakpoints. And if you see, streptococcus has no resistant breakpoint in case of penicillin. Almost all other streptococci is going to be susceptible to your benzyl penicillin, or there will be a non-susceptible because there is no resistance which is there in streptococcus for the penicillin, and because it is associated with fitness cost. And streptococcal endocarditis therapy is based on the penicillin MIC, whether you're going to give a adjunctive gentamicin or no. And important thing, Pseudomonas aeruginosa, there is no gentamicin breakpoint. Amikacin breakpoint is there only for urine, and tobramycin netilmycin breakpoint is available, but it does not correlate, or you cannot cross relate with the other amino glycoside. And remember, Pseudomonas species other than aeruginosa, none of them have this diffusion breakpoints. You have to do the MICs only. And Stenotrophomonas maltophilia, there is it has been clearly mentioned what has to be done by diffusion and what has to be done by MIC. And recently, ceftazidime has been removed as a treatment of choice for there is no MIC, and this diffusion breakpoint was available for ceftazidime. And there is also comments that levoflox should not be used as alone, and Cotrim also should not be used alone. It is a combination therapy which should be done. Burkholderia cepacia complex, again this is one of the evidence where the breakpoints has been changing constantly. Currently, there is no diffusion breakpoints, no MIC breakpoints. You should be reporting as epidemiological cutoff. That is, whatever reports, you shouldn't be using susceptible resistant at all. You should be just reporting the MIC. So this brings to the last slide. So these are my take-home points. Culture plus clinical context should always go hand in hand. You should decide whether it's a pathogen, contaminant, or a colonizer. You should identify the organism first, then interpret the AST only after knowing what type of bug you're dealing with. Neither the MIC nor the zone means anything without the breakpoints. You should know your intrinsic resistance, and you must recognize the resistance pattern, whether that's MRSA, ESBL, and the site matters. You should choose the right drug based on the site of infection. The AST will guide you, but clinical judgment is what helps you to decide the antibiotic. So thank you. I think I exceeded by few minutes. So
Yeah, thank you, Akshata. Wonderful talk. We'll have few questions. So some of the questions which I noted was, should we provide breakpoint chart to every clinician with the report?
just a second, ma'am. Whether I have stopped sharing or no, stop sharing. Sorry.
Not yet. Yeah, you can
Huh.
talk.
Okay, ma'am. So, breakpoint, clinical breakpoint should be provided, but no, like there is also a concept of giving therapeutic BMQ, breakpoint to MIC in the quotient. But MIC with the breakpoint is what should be provided so that we can choose the drug based on the which has lower MIC and which we feel can attain the levels in the site of infection.
Which method should be used for candida culture?
Candida, again,
Susceptibility.
the disk diffusion breakpoints have been there, but it's less reliable. You have to do the BMD only, that is the gold standard. And Vitek method is not reliable for Candida.
Is there any guideline for SGD dose for pediatrics? Is it different for adults and pediatrics, or is it the same?
What, ma'am? I didn't
For
get you.
SDD,
SGD, what is
is
SGD?
SDD
S
susceptibility with the,
Okay, SDD. Okay, okay.
yeah.
So pediatric dose again no. Whatever the values is given is for the adults. For the pediatric, we don't have SDD. We cannot use it basically SDD.
And the question is, how do you interpret the differences between ertapenem resistant and meropenem intermediate if there is a report?
Okay, at like I would be considering it as resistant only, because ertapenem resistant, meropenem intermediate, ma'am.
Yes.
Okay, that can happen, but I would be treating it as carbapenem resistant infection only, clinical.
And another question is, can we do VAN by E-strip test for MRSA?
Yes, it can be done. The IDSA also mentioned explicitly e-test to be done over even the BMD. So it can be done, and for the especially the isolates which have indeterminate values.
Okay, so maybe there are a few questions which we have not discussed. You can check them in the chat. We'll move on to the next talk. Thank you very much, Akshata. Let's
Thank
move on.